Hello, my name is Andrea, and this is Joshua, who will actually be Jesus, who has osteochondritis dissecans of the lateral femoral condyle.
I am a 24-year-old male who has been a referee for the local high school for 3 years. I've been playing soccer since I was 7 years old, and I played color soccer for 4 years. For the past few months, I've been experiencing aching pain on the lateral side of my right knee. I've also been experiencing clicking and locking while playing soccer or extraneous activity. And in order to help me out, I've been externally rotating my foot so that it puts less pressure on my knee joint.
So after having a positive Wilson test, Jesus had imaging done and found a complete detachment and loose body found between the tibial femoral joint. A stage 4 OCD lesion was found on the lateral femoral condyle. The doctor decided the best option was to surgically repair it with OATS, which is osteochondral autograft transplantation, on April 1st.
So clinical findings, he had mid-patella, 20 centimeters on the right side and left was 16 centimeters, which means he had a little bit of swelling. And above the patella, he had 18 centimeters on the right side and 22 centimeters below, which means he had a little bit of atrophy. And below, he had 20 centimeters on the right side and 18 on the left side, which means a little bit more swelling. He has limited range of motion on his right side, which is only 50 degrees compared to his left side. It's 140 degrees. And then he has a +5 on extension and a -5 on the left side, which means his extension is lacking just by a little bit.
Pain scale out of 10. In rest, he has 5 out of 10, and he has 8 out of 10. His right quad actually does not activate, unlike his left quad, and we have him non-weight bearing for at least the first 2 weeks.
So symptoms of this condition can be aching pains, mild swelling. They can be worsened with strenuous activity. Clicking or locking as the pain may become loose, limited active and passive extension, quadricep muscle atrophy, and external rotation during gait for the tibia.
Mechanism of injury. These lesions are generally for unknown reasons. Many believe that it can be genetic. It's more common again on the younger population because of the repetitive sport movements, but it can persist in the older population if it is not treated early enough.
Avascular necrosis happens whenever the blood loss is to the bone, so this can cause OCD as well, because once the bone part dies, it can break off and become into the joint of the tibiofemoral joint. Lesions become symptomatic during child development and can occur because of repetitive trauma to the knee, also known. So whenever the natural shape of a meniscus is a C shape, it turns into an oval shape instead, or that's how they were born with it. So it causes OCD.
There's 4 different grades of OCD. The first 2 are stable, so grade 1 is generally normal, articular cartilage, intact lesion. Grade 2 is a lesion with early separation. Grade 3, grade 4 are unstable. So grade 3 is partially detached lesion, and grade 4 is a crater-like lesion with or without loose bodies. Jesus actually has grade 4.
With a loose body.
Yes.
So a description of an OCD is generally affects the femoral condyles of the knee and can cause quad atrophy. The lateral femoral condyle generally involves a larger area than the medial femoral condyle. So these are the condyles, and this is where the OCD would typically happen here. The medial and lateral femoral condyles are covered in articular cartilage, which attaches to the bone underneath, which means that this cartilage here gets broken up and attaches, even though it attaches to here.
So the bone underneath is injured, so it damages the blood vessels, and the area of the bone does not receive the blood flow, and it dies, and it can be seen in x-rays. Some concerns are patellofemoral pain, atrophy during immobilization, generally the quads, and infections after surgery.
So we have 4 phases. In phase 1, it's going to be non-weight bearing with crutches, and then partial weight bearing as he progresses between 0 to 6 weeks. So our goals are to relieve pain, swelling, spasm, and protect injured tissue and prevent deconditioning. One of our 3 major goals that we made for Jesus were go from 20 centimeters to 16 centimeters in the patella, mid-patella, and then go from 20 centimeters to 18 centimeters above and below the patella. He'll be able to passively extend to -5 degrees and return to range of motion and flex and knee to 90 degrees. And then he'll also decrease pain from 5 out of 10 to 1 out of 10 during rest, and 8 out of 10 to 3 out of 10 during movement.
Some of the exercises we have are heel slides, prolonging the extension. So heel slides will be performed 4 times a day for at least 5 minutes. I would also have Jesus perform quad sets, so 5-second holds for every 10 seconds for 3 minutes 3 times a day. Other actions that we do is patella mobilizations and ankle pumps would be important as well. Phase 2 is the active phase, so it's partial to full weight bearing, week 6 through 12. The major goals are to restore range of motion, flexibility, and tissue mobility.
The patient will have 140 degrees of flexion and maintain full knee extension, by week 7. So he's pretty much full range of motion at this point. He also increased neuromuscular control of the quad, and without assistance, be able to start standing. And then by week 12, we're going to have him walk without any crutches or anything.
So we have a few different types of exercises. I would have them do quad sets again, have them do mini squats as well. So 10-second holds, 60 degrees, 3 times a day. Also heel raises would be important, 1 minute with 30-second rest in between 3 sets for 3 times a day. Calf stretches, hamstring stretches, and quad stretches would be very important in this phase, which would be maintained throughout his whole rehabilitation. Phase 3 resistive is going from unilateral exercises to multiplanar, weeks 12 to 26. The major goals are restore muscle strength and endurance, proprioception, balance, and agility.
So in order to get these goals, we made goals for Jesus, ideally that would release single leg stance for at least 30 seconds by 14 weeks. He'd be able to do squats and lunges for 3 sets of 10 without any pain at 16 weeks. And then he'd also be able to build up endurance on a resistance spike of 4 in a stationary cycle for 10 minutes without any rest. So normally he takes a little bit of rest in between, and so we're going to build up that endurance. We're going to increase the quad girth measurement from 18 to 22 centimeters by 24 weeks.
So some of the exercises we have is leg presses, also lunges, forwards and backwards. It would be walking lunges. Also, we could do single leg stands, cone touches to increase proprioception and balance and agility. We have sports cord and importance of rhythmic stabilization on a single leg as well. Phase 4 is the last phase. It's aggressive. So main goal is to return this athlete to play. It's done usually week 26 to 52, and we're going to involve plyometric functional exercises as well.
So with our goals here, we're going to get goals that are going to be exactly what he's going to be doing once he returns to soccer. So he's going to start doing some zigzag drills. He's going to start doing wind sprints. He's going to start building up the endurance that a soccer player needs to run the multiple miles that they do during a game. The patient also returned to restricted team practice by week 40, and then return to full competition by week 50.
Some of the important exercises would be jumping over cones, zigzag cone drills, ladder drills, a lot of drills that are involved specifically for the sport, soccer. So we have operative and non-operative. Major differences for a stable lesion for non-operative is to reduce the weight bearing and reduce the stress in that area. And it will be important to increase range of motion and strengthening exercises as well. If the symptoms last for more than 6 months and there's no significant healing in the tissue, it will be important to go into operative treatment. Operative treatment generally for stable, it involves drilling channels into the lesion through either transarticular or transfascial approach. This is to initiate the healing response in the tissue. Research shows that it reported in a skeletal immature knees, it was 100% radiographic healing in 4.4 months.
This then adds an extra 6 months onto the rehab that he already has done, so it takes about a year to have full recovery. So in an unstable lesion, there's a non-operative treatment, which is not the ideal plan of action. It takes about 4 to 6 weeks without any weight bearing, and then he goes from no weight bearing to 3 to 4 months, where he might be able to gradually return to sport, and then an overall return would be 10 to 18 months. But there's only 50% chance of healing, so they don't likely do an unstable lesion. What they do is either a fragment excision or fragment fixation. The fragment excision is where they take out the loose body in a knee that's hanging out in the middle of the joint. The fragment fixation is where they put it back into that little divot that it's created. Our patient opted to do an oats.
So it's osteochondral autograft transplantation. Pretty much it involves the transplantation of bone plugs and overlying articular cartilage. They are harvested from non-weight bearing areas of the knee. It is limited though because the amount of donor tissue available. There's a lot of research on it, and it says, despite these limitations, results from isolated small, medium-sized lesions of the femoral condyle have been good. Greater than 3 years, 91% of cases had good or excellent results.
So with this surgery, you can come back. Potentially, the longest period is about 52 weeks plus, but that's like safely returning to full potential.
So, thank you.
And these other resources, thank you very much.